Hello, and welcome to Upward MD. This is the beginning of our pathology series. So we're going to cover chapters one and two. Chapter one is the introduction to pathology, and then chapter two is going to be cell injury and adaptation. Now, this information is not going to have a lot of specific questions on it for your exams, but it sets the foundation for pretty much everything else we cover in pathology. So, starting with the introduction, really what we're talking about is how to visualize the pathology we see. And we do this via stains, microscopy. So, to start us off, the most basic stain is the H&E stain. That's hematoxylin and eosin. Hematoxylin stains nuclear structures purple, and the eosin stains proteinaceous structures pink. So, we're going to see this time and time again. It's really just to visualize the cell, see its nuclear to cytoplasm ratio, essentially, because the cytoplasm is full of protein. Then starting from left to right, we have Prussian blue. Prussian blue stains iron blue pretty notably. As you can see in the picture, this red blood cell is covered with iron. This is a sideroblastic anemia where the iron can't be incorporated into hemoglobin. And so it's just going to surround the cell, uh, indicating the pathology, right, which is sideroblastic anemia. You can see it as well in hereditary hemochromatosis if we were to give you a liver cut section that was stained with Prussian blue, because then you'll see the iron deposition in the liver. Next to that, we have Congo red. Congo red without the apple green birefringence looks pretty similarly to H&E stain. It's pretty hard to tell that it's anything different, but when you put on that apple green birefringence, when you put it under polarized light, it's going to glow green. And that's going to tell you that there's an amyloid deposition somewhere. This is a kidney glomerulus. As you can see, this is a sign of amyloidosis, which will cause a nephrotic syndrome in the kidney. Next to that, we have our acid fast or Zeal-Nielsen stain. This primarily stains mycobacteria, which is Mycobacterium avium intracellular complex and Mycobacterium tuberculosis, but it will also stain Nocardia species, which are all pretty similar. The reason for this, it has a different cell wall that won't respond well to H&E stain, but it'll respond well to the Zeal-Nielsen or acid fast staining. Next to that, we have reticulin. This is the black outline of these cells. Reticulin stains type 3 collagen, which is like our stretchy type collagen. The only time I've seen this really asked is when we're talking about the lung parenchyma, what surrounds the alveoli to allow them to stretch. When you stain it with reticulin, you can really see the outsides of the alveoli well. Just below that, trichrome. Trichrome I haven't really seen, but is worth throwing in because it's pretty noticeable. Nothing else really stains red and blue like that, and it just stains for type 4 collagen. As you can see, this is a kidney as well. And then last in the bottom left corner is our Sudan red. Obviously, it stains red. It stains fat red. So that's pretty telling as well. You just have to know the stain so you can tell what's going on in the picture. Moving on from that, chapter two, we're getting into cell injury and adaptation. So injuries, just talking about definitions here. Hypoxia is the lack of oxygen to a cell. Ischemia is the lack of blood to a cell. And then other injuries can be infection due to immune damage, genetic abnormalities, chemical injury, physical injury, nutritional deficiencies, all that stuff. I just put it in for completeness sake. But we're only really going to see hypoxia and ischemia for 90% of questions. Now, when the cell is injured, it adapts. There's reversible adaptations and irreversible adaptations. Irreversible usually lead to cell death, which can be characterized by necrosis, apoptosis, or necroptosis. Necroptosis is just a combination of both necrosis and apoptosis. So it looks like apoptosis, but has inflammation as well. Typically, apoptosis has no inflammation at all. And then there's atrophy, hypertrophy, hyperplasia, metaplasia, dysplasia. We'll get into all these later. So, reversible versus irreversible injury. Signs of reversible injury really are just cell swelling and endoplasmic reticulum swelling, and then decreased pH, because usually due to ischemia or hypoxia, the cell does not have the oxygen for its mitochondria to produce ATP, and the swelling occurs because there's no ATP in the cell to fuel the sodium potassium ATPase. Remember, the sodium potassium ATPase exchanges potassium in for sodium out. So if it stops working, sodium is going to come in, and sodium always draws water in with it. So that's how you get swelling. The irreversible changes are going to be damage to the DNA, blebbing of the membrane, rupture of lysosomes. Rupture of lysosomes will lead to a liquefactive necrosis, and that's pretty much cell death, inflammation. And then one other key point. in just in general, when we do laboratory values, when we have damage to tissue, let's say you have a heart attack, you're going to have elevated troponins. The reason you have elevated troponins, it's really just measuring the amount of protein in the blood, right? Typically, these cardiac proteins should not be in the blood. But if that heart tissue dies, the membrane is going to break and release those proteins into the serum. When you have high levels of that, you can measure it on a laboratory test, and that will be diagnostic of cardiac injury. Same goes for liver injury with elevated AST, ALT. So these are cell-specific proteins that leak into the serum, into the blood, when they shouldn't, right? Now, starting with necrosis. Uh, just as a reminder, apoptosis, no inflammation. It is cell death that is signaled through caspases, typically. Necrosis is unplanned cell death, usually due to a rupture of lysosomes. That's how you get your liquefactive necrosis. Um, but anyway, here are the different types. So coagulative necrosis is usually due to ischemia or hypoxia. You get dissolution of the nucleus, but preserved cell shape. So they call them ghost cells. They're just a pink little box with nothing in it. When I say loss of the nucleus or dissolution of the nucleus, that's what I'm talking about when I talk about karyolysis over here on the left. Karyolysis is the dissolution of nuclear material. As you can see pycnosis and karyorhexis in apoptosis. That is DNA clumping and gathering so that it can be digested. But karyolysis is complete dissolution. It's complete breakdown, and you only see that in necrosis. Now, like I was saying, liquefactive necrosis, this is when lysosomal enzymes dissolve the cell components. You can see this in abscesses, so bad infections, right? White blood cells, neutrophils gobble up bacteria, and then they die and release their lysosomal enzymes. You can also see this in brain infarct. So if you have a stroke, a thrombotic stroke to the brain or thromboembolic stroke to the brain, it will lead to a liquefactive necrosis. And the pancreas can also undergo liquefactive necrosis. Usually after acute pancreatitis, you can get necrotizing pancreatitis. After that, we have caseous necrosis. Caseous just means cheese-like. It's a mixture of coagulative and liquefactive necrosis. And this is almost always seen in granulomas. Usually you see caseating granulomas. This is characterized by tuberculosis, Bartonella, which is cat scratch disease, and then fungal infections. Fat necrosis, it's usually when a fat cell gets damaged, like usually traumatically. So classic case is when a woman accidentally runs into a wall or a door, hits her breast, and some of the fat in that breast will actually break, and then calcium is going to combine with it to make a hard mass, and that's fat necrosis. Fibrinoid necrosis, this is usually immunoglobulin protein being deposited in tissues, typically the vasculature. It's fibrinoid, which means anytime you see oid, it means like. So it's like fibrin. Fibrin is a protein. It's a long fibrillary protein. It's going to lay down in the vessels and lead to this fibrinoid necrosis. And now, lastly, gangrenous necrosis simply just means completely dead tissue. There's dry gangrene, which is a coagulative necrosis, and then there's wet gangrene, which is a liquefactive necrosis. Typically, you see gangrene in the feet of diabetic people. Gross. Now, apoptosis, like I said, there's no inflammation in apoptosis. It can be physiologic, like in embryology. When you're growing, your hands are like mitts, and then slowly the cells in between your fingers die off. That's physiologic apoptosis, as well as in the endometrium during menstruation. There's apoptosis of the endometrial glands, which allow the tissue to slough off when women get their period. Now, there's two main pathways. I'll say two and a half, really. There's the intrinsic pathway and the extrinsic pathway. The reason I say two and a half is that extrinsic could be mediated via the FAST receptor or via humoral signals, TNF alpha, typically. So the intrinsic pathway, as we can see in this picture, is when there's irreversible DNA damage, and that DNA damage it causes activation of P53, which activates Bax and BAC. I always say those are the bad boys. And then that goes to the mitochondria to release cytochrome C, activating caspases 9 and 3, and then these are what cause dissolution of the cell material. The extrinsic pathway is similar, but via those signals. So the FAST receptor is produced by CD8 positive T cells. It's also produced by natural killer cells. It binds to the cell and says, okay, it's time to die. And then you see this procaspase 8 and 10 activate the same pathway. So we call that activation the fast associated death domain, but follows kind of the same pathway, just using caspases 8 and 10. So I don't know how high yield the numbers are, but just know that really caspase 9 is our executioner caspase, which activate everything else. 8 and 10 are specific for the extrinsic pathway, and then the rest kind of do everything. And then it's worth to know the anti-apoptotic factors are BCL2 and BCLX. The reason that's important is BCL2 is upregulated in follicular lymphoma, which makes it super hard to treat because no matter what you throw at it, these cells won't die. And P53 as well, that is seen, the mutation in P53 is seen in Li-Fraumeni syndrome. So if you can't activate P53 to kill the cell, you're going to get cancer. And that's why Li-Fraumeni, the P53 activation, or sorry, mutation to inactivate it, will lead to disseminated different primary tumors all over the body. Moving on to something a little lighter, atrophy, hypertrophy, hyperplasia. Atrophy is just the decreased size and function of cells, usually due to disuse. So when somebody breaks their arm and they're put in a cast for 6 weeks, they will have atrophy of the muscles in their forearm because they're just not using them. Ischemia, one example that I like to use is peripheral artery disease. It's decreased blood flow to the distal extremities, so usually the lower leg. That's why your Grammy or granddad probably doesn't have lower leg hair because everybody, as you get older, you get more atherosclerosis. And then if there's a decreased blood flow, the skin will receive less blood and the hair cells, the keratinocytes are going to die off. And the epithelium, the skin epithelium is going to become less nourished and you're going to get bald, shiny legs. Or I should add on to atrophy, lack of stimulation with our hormonal tissues. What I threw in was testicular atrophy in somebody who uses anabolic steroids. Hypertrophy is just increased cell size. So think muscle, weightlifting, the heart with hypertension. And then there's hyperplasia, which is increased cell number. The only cells that can't undergo hyperplasia are nerve, cardiac, and muscle cells. So typically hyperplasia is in response to hormonal stimulation. So estrogen on the breast or endometrium, the DHT on the prostate, or it could be due to infection, but really only with our white blood cells, lymphoid hyperplasia. You can see that in the appendix, and that's what causes appendicitis in kids as well. Metaplasia. Metaplasia is interesting, but by definition, it's the conversion of one mature cell type to another mature cell type. You see this in the esophagus with Barrett's esophagus. Constant inflammation from gastric acid is going to change that squamous epithelium to columnar epithelium. That's actually like intestinal columnar epithelium because the body thinks it's a better response to that stress. It can survive better. But the danger with metaplasia is that if you keep irritating the tissue, it can turn into dysplasia, which is uncontrolled cell proliferation. You see this with different cell shapes and sizes, loss of orientation, and increased nucleus cytoplasm ratio. And the reason this is dangerous is it's a precursor to cancer. Now, last part of injury are the accumulations. So just I threw a few on here. Really, it's good to know these, but there's no rhyme or reason to it. Uh, One example is in the liver. If you have chronically high triglycerides, you can get hepatic steatosis, which is just liver deposits in the liver, sorry, fat deposits, lipid deposits in the liver. Uh, Further, you can get hyaline accumulation, which is just proteinaceous. It's like fibrinous uh, protein buildup in cells, typically in the vasculature. You can see this in prolonged hypertension or amyloidosis, calcium or calcific accumulations. This is a little bit more interesting. On X-ray, they glow white, as you can see on the right here. This is a pancreas, and there's three little white dots. Those are all chalky white calcium deposits. Now, I put that on because there's two types of calcification. There's dystrophic, which can occur only in damaged or necrotic tissue. So pancreatitis is a great example. Papillary thyroid or meningioma cancers, Samoma bodies can actually accumulate calcium, and that's a dystrophic calcification. But usually it means serum calcium levels are normal. Metastatic calcification. This occurs in the setting of hypercalcemia, where normal healthy tissue is going to become calcified. You can see it in calcific aortic stenosis if somebody has, let's say, primary hyperparathyroidism. They have too much calcium, too high of calcium, and then your soft tissues are going to get calcified. A couple other ones that are worth to know. Lipofuscin. I feel like I always see a question on lipofuscin. It's this picture on the bottom left. It's this brown or yellow pigment in normal healthy tissue. It's just a wear and tear pigment in old people. Usually it accumulates in lysosomes and it's in heart tissue pretty commonly. And then lastly, anthracotic pigment. This is a workplace exposure. When coal deposits in the lungs, you can see coal, like obviously black pigment from the coal, um, known as coal workers pneumoconiosis. And that covers our chapters 1 and 2. So thanks for coming and tune in for the next one.